Let's go ahead and call this meeting to order. If you'd join me, as is our honor and privilege, stand for the Pledge of Allegiance, especially on this week of election and Veterans Day, takes on special meaning. I pledge allegiance to the flag of the United States of America,
United States,
and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. Thank you very much. Roll call, please.
Director Yee,
Present.
Director Stewart,
Present.
Director Wallace,
present.
Director Eben,
Present.
Director Nicholson.
Present.
Very good. Thank you. And who is in the boardroom with you, Dee?
In the boardroom, we have Kimberly Hartz, Chris Henry, Tina Nunez, Larry Labossiere, Paul Kozachenko, Shri Badu, and me, D'Antonio.
Okay, great. Thank you. Well, welcome to the November 9th, 2022 regular meeting of the Washington Township Healthcare District Board of Directors. To continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by the SARS-CoV-2 virus, the Brown Act allows the local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Healthcare Services Public Health Department COVID-19 website at www.covid-19.ac.gov.org. I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
So moved, Madam.
Thank you, Dr. Stewart. Is there a second?
Second.
Check.
Okay, thank you, Dr. Nicholson. Thank you. A roll call vote, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Eben,
He's having trouble there.
Dr. Eben, you're on mute.
Sorry. Aye.
Dr. Nicholson.
Aye.
Very good, thank you. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom, and I ask you to please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Moving on our agenda into communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Are there any written communications, Dee?
No, there are not.
Very good. Then we will move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none, does any member of the public want to remove an agenda item from the consent calendar? Very good, then may I have a motion to approve the consent calendar items A through F, please?
I move that the Board of Directors approve the consent calendar items A through F.
Thank you, Dr. Eben. Is there a second?
Second.
Thank you, Dr. Stewart. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Eben,
Aye. Aye.
Director Nicholson.
Aye.
Very good. Thank you very much. All right, presentations. There are a couple of presentations this evening, and I'm going to have Kimberly introduce these, please.
All right, thank you, Madam President. I'd like to start with introducing Dr. Matthew Tenhold. He is a hematologist-oncologist who joined the UCSF Washington Cancer Center in 2021 and cares for patients with a wide variety of cancers and blood-related conditions. He earned his medical degree from Albany Medical College. At the University of California, Davis School of Medicine, he completed a residency in internal medicine and a fellowship in hematology and oncology, serving as chief fellow. Dr. Tenhold's firsthand experience in being treated for and cured of lymphedema sparked his desire for a career in medicine and his enduring passion for providing care throughout each patient's cancer journey. Outside of work, Dr. Tenhold loves spending time with his wife, a pediatrician, and 2 sons. So this evening, he's going to present a very interesting talk about intermittent fasting.
Well, thank you very much, Kimberly, for having me this evening. It was actually my treatment for lymphoma many years ago. Thankfully, I didn't have lymphedema as a result of that,
Sorry,
but that's okay. And actually, much of my research background is actually focused more on leukemia, lymphoma, and a focus in hematologic malignancy. But in coming here, I've actually been caring for many patients who have been suffering from breast cancer, among other malignancies that may actually benefit from intermittent fasting. And so it's become a very popular topic in our community. It's something that many people are very interested in learning more about. So I began to investigate this myself a bit, to try to best advise on it. So we talked a little bit about this at a community outreach presentation that I gave, and it's good to share with you all today. So intermittent fasting, this is a discussion about how it will help potentially with cancer treatment, harm cancer treatment, and help with other conditions as well. And so what it involves, what is intermittent fasting, or what is fasting in general? We talk about 4 different sort of main types of fasting that are out there. So calorie restriction would be better understood as simply dieting, so just reducing your calorie intake and doing this over a long period of time without much modulation there. Intermittent calorie restriction is periods of shortened dieting that may occur on certain days, but is not specifically fasting itself. Now, fasting is basically complete avoidance of calories, and this could last anywhere from a day. It could be certain sets of hours. It could be several weeks. And when we get a little bit more closely in defining this, we would call this intermittent fasting, when we are specifically choosing a period of time during the day where we are doing this. Alternate day intermittent fasting is another way that this is defined, where a person could fast on alternating days and have this in a more organized fashion. So we'll talk a little bit about fasting biology first. This is not intended to prepare you for the medical boards or anything like that, but we'll be diving into some of these topics. So feel free to breeze through it. But what we'll talk about here is basically the human body is made of trillions of cells. All of our cells have complex machinery that allows us to function, to survive, our cells to reproduce. And these cells require energy. Energy comes from our food primarily, and this allows our cells to grow and to function. And as we go through these pathways, you can see here this massive diagram covers most of the things that many of us probably had to memorize for our initial medical licensing exam and so forth, and hopefully remember some of it, but we won't have to cover all of that today, thankfully. So the basics, though, of metabolism are fairly the same throughout all organisms. So this is something that is very similar amongst bacteria, plants, humans, elephants. It really is something that is very similar and fairly consistent across most living things. And so part of the process of our metabolism deals with catabolism, which is breaking down a source of energy to, such as food, to release that energy so it can be used for other resources. And anabolism is actually the process of using that energy so that we can grow and build something new, like new cells. Now, when we talk about fasting and starvation, many of our bodies are essentially designed to thrive and to adapt to starvation, so we do not actually suffer and die from this. And so we have many mechanisms that our body is able to enact when we are short on energy reserves. And when we have to tap into energy reserves, we have other mechanisms that allow us to do this so that we can continue to grow and produce new cells and essentially survive. So Many of these pathways are enacted as a person is fasting. Many of them are enacted when a person is processing food and is growing. So some of the most important ones that relate to cancer biology are the following. So the IGF-1 or insulin-like growth factor 1, insulin itself, and the sex hormones testosterone and estrogen are highly influential of cancer and tumorigenesis. So how are these affected by fasting? So what ends up happening is that if we have calorie intake occurring, many of these of those factors, such as insulin, will end up going down as our calorie intake goes down. Insulin will go down as this occurs. Cortisol will actually go up. The sex hormones will decrease. So a variety of these hormones are actually influenced as we're taking in food or avoiding food. Now, mutations, which is damage to the DNA, these will occur and, of course, are well-known parts of cancer development. And many mutations that actually contribute to cancer development are involved in these pathways. So several targeted therapies that we're now using these days for treating a variety of cancers are actually interacting directly with many of these metabolic pathways that are involved in fasting and growth and development. And as we are going through this, we will see that some of these can actually be influenced by our treatments as well as possibly fasting. So again, as we are going through this, the calorie intake, as it decreases, many of these hormones actually decrease. Some of them will increase, such as adiponectin, but many of the driver hormones that are involved in cell development and growth will actually decline as calorie intake decreases. As a result of that, many of these, the expression of the actual products of the genes involved in these pathways will also adapt and decline as a result. So in theory, what we are doing by fasting and reducing energy intake is we're actually depleting some of these mechanisms that may actually be driving cancer development and cancer growth. Now, at the same time, what we end up having to worry about here is making sure that the rest of our healthy cells will grow and function as well. And basically, the idea being that if we are able to reduce energy sources, reduce calorie intake, we may be able to differentially affect how these influence the development of a cancer cell and influence our normal healthy cells. So the theory being that if we decrease this mechanism or decrease this calorie intake, we end up with mechanisms that basically cause development of cancer and drive cancer growth being reduced. And that cancer cells may actually not have the same mechanisms in play that our healthy cells would have to adapt to this. So, looks like my presentation has paused here for a moment. Apologize for that. Try this again. Are you able to see my screen still?
Doc, no, I can share it from my screen and I can help you advance the slides if you want.
Let's see here. Okay, sorry about this. It seems that our connection here has dropped out.
Is this a slide, Doctor?
Let's see here. I actually don't even see the Zoom screen anymore. I apologize for this. Yes, so we are here. Yes, that's correct. Thank you so much.
All right.
Not sure what happened here on my end.
No worries.
All right, so basically what we end up having occur is that as we reduce these mechanisms that are involved in cancerogenesis by reducing fasting and calorie intake, we end up reducing cell proliferation. We can end up increasing the removal of damaged cells. We end up having mechanisms in place that may actually lead to damage to cancer cells and destruction of abnormal cells. So the theory being that this decreases the incidence of cancer. So we can go to the next slide there. Thank you. So as a general overview, all of these mechanisms that are in play here end up influencing the risk of cancer development. So these would be increased fat cell activity, increased insulin resistance, increased inflammation, increased estrogen production, the need for higher insulin levels in the body to actually function. All of these things actually influence the generation of new cancer. And additionally, all of those increases lead to production of new cells at the same time, decrease in the destruction of aged and dying cells, and also increase in the rates of damage to the DNA, of course, leading to the possibility of new cancers to develop. So This would be the mechanisms behind why this may work. Go on to the next slide there. So lots of data behind all of this, but much of it is actually bench research. So very few studies are actually evaluating what is happening for the individual person. But the bottom line is that many of the sort of nutritional physiologists and PhDs behind a lot of this have discovered that the bottom line being, we need energy to survive, but we have many ways to adapt to a loss of energy, a loss of intake of food and new calories. And our healthy new cells may actually be better at adapting to that than the cancer cells are. And so as we're having a lower calorie intake, we end up upregulating these processes that may actually destroy the cancer cells. We end up basically putting the cancer cells in a situation where they're less able to adapt and they starve, whereas our normal healthy cells are more likely to go into a dormant state and end up surviving this. So ultimately, also, we have other mechanisms that with high calorie intake may directly promote the development of new cancers and allow for a cancer to thrive. So general things that have been found as a result of fasting. So there have been a variety of studies that have been done and a variety of avenues, both in cancer as well as outside of cancer. We know that overweight people tend to lose weight. It's a modest reduction in weight that typically happens, but it is possible with fasting to do so. There may also be other benefits such as increased energy levels, improved self-esteem, self-image, and these are all good things, of course, to have. It does lower insulin resistance, and some patients are actually able to come off of some of their anti-diabetic medications. So, for example, reducing the amount of insulin a person may need, or being able to come off of an oral medication if they're having improvement. I always encourage patients that they shouldn't suddenly stop taking their insulin without talking with their doctor, of course. Blood pressure and heart rate may also improve with fasting. Theoretically, the risk of a heart attack may be reduced or stroke may be reduced, but this hasn't been actually proven or even studied really in humans at this point. It has been demonstrated in animal studies. There's a definite benefit there. There are studies that suggest some improvement in wound healing. These are studies in animals as well. This is not something that has been really evaluated in the surgical literature, so not really ready for prime time in terms of what our surgeons can recommend. And there seems to be an improvement in memory and thinking. And this is something that anecdotally many patients will share, and other individuals or physicians I work with, for example, will share that when someone is doing intermittent fasting, actually there's this sort of clarity of thought that begins to particularly affect the early morning part of the day. And some people do show this verbal improvement that occurs, an improvement in verbal memory that has actually been studied in humans as well. Now, calorie restriction and cancer, how this may actually pan out in studies that show an effect. So there were early studies in the early 1900s that essentially showed in animal studies that there was spontaneous reduction of tumor size and improvements in tumors with fasting. There have been more recent studies that have shown that fasting in combination with chemotherapy may increase the anti-tumor effect in a variety of tumors. And so this has been looked at in brain tumors, gliomas, as well as melanoma, breast cancer, neuroblastoma, and ovarian cancer. However, these studies are quite small. And perhaps the most important study that has been involved in this is actually in breast cancer. So there was a very large study performed involving over 40,000 women, and 2,413 of those women were breast cancer survivors. And what they discovered was that with intermittent fasting, and this was intermittent overnight fasting, with including about an average of about 13 hours of fasting overnight, there's actually a 36% reduction in the risk of recurrence of breast cancer compared to those who were not fasting. And this is in breast cancer survivors again. Now, there was also within this a 21% less likely to experience a breast cancer mortality event. These women also experienced lower A1C, better sleep. There was a slight decrease in the actual hemoglobin A1C that led to some patients being able to discontinue anti-diabetic medications. Lower CRP was seen, which is suggestive of lower chronic inflammation as well as possibly acute inflammation. So this was actually one of the more high-powered studies. Now, another study that is cited frequently by oncologists and is even on our UCSF health and wellness website is this study, which I can't really advocate for. So this was published back in 2016, a much smaller study. So this study included only 6 patients, which is incredibly small, very difficult to get any kind of statistical information out of such a small study. However, they seem to present it here in the graph on the right. There was a variety of different chemotherapy regimens used. There were a variety of different cancers involved, and durations of intermittent fasting and prolonged fasting were used as well. They reported that there were fewer side effects of the chemotherapy. So essentially fatigue and weakness was reduced. The frequency of mouth sores and dry mouth was reduced. But again, they have no statistical reporting actually in the data. And they report that the patients involved in this had some increased hunger and lightheadedness, but again, this is a bit underexplored, we'll say. Now, when we go back to the big picture here of why intermittent fasting. So again, just to review, this is complete avoidance of calories for a period of time each day, or doing alternating day on, day off fasting, or potentially 2 days fasting, and 2 days off. And so this would be the approach. Again, what this can be helpful with is calorie restriction and dieting. We can see that this can be helpful if someone is overweight. It could potentially be very harmful if someone is already underweight or they're undergoing an intensive treatment like chemotherapy for the cancer. It does tend to lead to weight loss for everyone, but in general, it may not be safe for everyone. Now, fasting, as we were saying, this begins to work rapidly. It actually begins to work within a couple of days from based on the bench research. And what we can see is that it seems to protect against weight loss initially. So it may not really be that helpful for people who are trying to rapidly lose weight. But in that sense, as we're talking about, we have protective mechanisms in this method that actually will protect our healthy cells and may end up injuring the cancer, which is our goal. Now, prolonged fasting, this essentially can become extreme calorie restriction. So for some people, this could lead to severe weight loss. This is certainly something that I would not advocate for when someone is going through cancer treatment. But again, here with intermittent fasting, we end up with this differential stress that ends up leading to potentially more injury to the cancer cells as opposed to the person and their healthy cells. Now, what does it actually look like? So the simplest approach is probably the approach that was used in the Women's Healthy Eating Initiative, and that was to do an overnight fast. So for many people, this is a very easy switch where they try to focus on eating a dinner at a reasonably consistent time. I always give an example of, say, 7 p.m. and then delay the breakfast until 8 a.m. And so with this, many people actually say oh, I'm already doing this. This is great. And this is something that's very achievable for a lot of people. And I've tried doing this myself. It worked out quite easily within about a week or two. A key thing would be to drink plenty of water. Feeling hungry certainly can happen in the morning. Getting a bit irritable in the morning can happen, and drinking water and actually having coffee can be a reasonable thing as well in this situation, because up to 15 calories is considered acceptable without actually breaking the fast. Some experts say that up to 50 calories may be reasonable to consider as well. However, it's a little bit more flexibility for a larger person, for example. Now, a longer fast is probably needed if your goal is to do weight loss. So many people pursue a 16-hour fast where they're eating dinner and they skip breakfast entirely, go all the way to lunch. The data for this actually is better for the goal of weight loss. It's more realistic that it may actually help with blood pressure, it may help with diabetes more significantly. But the data with regard to effect on an anti-cancer effect is not really well explored with that longer duration of fasting. It can be discouraging to try to push out pretty far in that sense. Many people just cannot tolerate going that long without eating too. Now, I usually just recommend starting with the usual routine, and cutting out late night snacking is actually the good first step to do. It's the most disruptive thing for sleep, eating really late in the evenings. It's also probably more strongly associated with weight gain than eating too early in the morning. And then as things move along, after cutting out the late night snacking, starting to move the breakfast out later and later in the morning, even in small increments like 15 to 30 minutes, and then moving out to 30 or 60 minutes later. And this can be done every 2 to 3 weeks, even over a slow period of time. And with that, adjusting to a 13 or even 16-hour fast is very achievable. Some people even pursue up to 18-hour fasts. One of my colleagues is doing a full 24-hour fast periodically throughout the week and has been doing very well with that. Now, short-term water fasts are what I was kind of just describing here, which is that every for 1 to 3 days, we would just drink water alone, no food at all, no calories at all. Now, this may actually trigger much more robust activity of some of these protective mechanisms that we were discussing earlier. It certainly is more likely to cause weight loss. This can be done, for example, Monday, Thursday, Saturday in a reasonable fashion, but this would not be something to just jump right into or start off with without kind of slowly adjusting to it over a few months. I have not tried to do this yet. I'm not certain that I ever will. But for me, the standard overnight 13 to 16-hour fast is going very well. Now, some other helpful tips here. So coffee is perfectly okay. About 1 to 2 calories per cup would be used in a cup of coffee. A low-calorie creamer, for example, coconut creamer is often less than 10 calories in the serving, so that's reasonable to consider. Sweetener substitutes are probably okay. There is some speculation about artificial sweeteners and saccharin sweeteners potentially having a carcinogenic risk and also potentially triggering the activity of some of the glycemic hormones that are involved. So the insulin like growth factor 1 being triggered by some of the artificial sweeteners may be a problem that's not well explored. Binge eating on junk foods when the fast is over. So this is a big pitfall for a lot of people who are trying to lose weight. So basically having your fast, you go all night, 13, 14 hours, and then suddenly you eat a gargantuan breakfast, and that kind of cancels out a lot of the benefit of avoiding calories. That is probably the biggest part of weight loss with this. Moderate protein intake is reasonable and may actually help for sustaining energy throughout the day. So avoiding really sugary first meal of the day would be helpful to make this more tolerable. So that would be another thing to consider. Now, some key takeaways, though, with all of this would be that intermittent fasting, a lot of the data is very preclinical. So this would mean that this is research performed in animals, performed in biochemistry experiments in a lab, and not really proven to be safe or beneficial in humans. Now, the breast cancer retrospective and prospective cohort data that has been evaluated is very convincing, and it is likely beneficial in that setting. There are clinical trials that are underway exploring the benefit of this in breast cancer to a further degree, also exploring this in prostate cancer, colon cancer, glioma, and lymphocytic leukemia, chronic lymphocytic leukemia. But many of the claims that are out there in the world on the internet, even on my own organization, UCSF's website, the Osher Health Center, some of the claims aren't really very well based in evidence, and in fact may put patients in a more dangerous situation if they're not careful with things. And so that's why I do exercise some caution with this recommendation. There is convincing evidence, as I mentioned, that it will help with breast cancer, and it's particularly in the setting of post-treatment for breast cancer. So these patients who were breast cancer survivors in the study had completed all of their chemotherapy. Many of these patients were on medicines intended to reduce estrogen and the hormones involved in potentially encouraging a recurrence of breast cancer, but these are therapies that are not nearly as intense and are certainly safer to make these kind of modifications alongside. I'm certainly not yet convinced that it's safe for patients who are undergoing intensive chemotherapy. Now, it's for some patients who are otherwise very healthy, who are fit, who have no other metabolic conditions like uncontrolled blood pressure or diabetes to begin with, and who are on a lower intensity type of treatment. I mean, it's reasonable to consider, particularly if they've done very well with their first few treatments. Certainly, a small amount of weight loss, some improved energy, these things are common to see. And for these reasons alone, it's probably worth trying for almost anyone who wants to, potentially reap some of these benefits. It's also very inexpensive. It's approachable, and it's likely very safe for most people outside of the intensive medical care setting too. So in summary, I think that this is something that, while it is very easy for many people to implement, it's low cost, it may be high yield. And myself, I have a family history, of course, as well of cancer. So I have individuals in my family with prostate cancer. I'd certainly like to avoid that, and this is something that this may benefit. The jury is out on whether or not it may benefit any history of lymphoma. There is a study exploring this in chronic lymphocytic leukemia, but it does not yet appear to be necessarily a benefit across the board for all cancers. So lots of things to explore with this, but certainly for many people, particularly many of our breast cancer patients who represent the majority of our cancer center patients, this is something that could provide a meaningful benefit.
Thank you, Dr. Tenhold.
Well, thank you very much.
Any questions from the other board members?
I have a question about, is there any data at all on once a month, 24-hour fast?
So there's not much data regarding that, that I'm aware of, at least regarding that short of a period. There is good data suggesting a benefit from a 24-hour fast that happens about twice per week. And so this will be one that's yeah, difficult. But that's actually Dr. Eftimia is pursuing that. So he and his wife have been doing the twice weekly 24-hour fast, which I think was a difficult thing to step up to. They were doing the overnight intermittent fasting for at least a year or two before they tried to attempt that.
Seems like you lose weight pretty quick doing that.
Yeah, you would think so. It's interesting though. It's actually, the body is so good at conserving energy and adapting to this that many people actually say they gain a little bit of weight when they first start doing the intermittent fasting instead of lose it. And with the overnight fasting, at least, it was a very modest amount of weight loss. It was about a 3% loss that was averaged. So with the small amounts of fasting with that protocol, it is really not a great strategy for weight loss. And even the 24-hour fast twice per week hasn't been as definitively proven for weight loss. However, doing up to 18 hours, 16 to 18 hours overnight every night, that certainly has been shown to have some weight loss potential there.
I find when I fast for a 24-hour period, I get really cold. My metabolism must really slow down.
Yes, it likely does, and that would be expected.
Yeah, I don't think you have much fat there, Dr. Stewart, to keep you warm.
Matthew, the question that I have is, have there been any reports that the incidence of some of these cancers are much less in, countries or endemic areas where there is chronic starvation?
Yes, so that's a very difficult question to answer for a variety of reasons. So that has been speculated in many retrospective approaches where we're assuming that that's the case. However, a big limitation in actually confirming that is that quality data coming out of areas that have endemic starvation, who are medically underserved, it's very unclear if the rates of cancer that are reported in those countries are actually accurate to begin with. So when a country is suffering from systemic starvation and the resources to provide the most basic necessities are so poor, medical care as well is also very poor. And the result of that is that many patients go undiagnosed with cancer, never receive treatment for cancer, may die of old age or natural causes without it ever being attributable to an advanced cancer that was actually underlying this. And so there's a lot of criticism about that claim, in the sense that we may simply not be making the diagnoses in countries that are suffering from severe starvation and systemic starvation like this.
Thanks.
Is there any animal data to support intermittent fasting? I recall that maybe 20 or 30 years ago, there was an animal model looking at chronic severe calorie restriction offered longevity benefit in an animal model. But has this intermittent fasting been studied in animal models?
So it has been studied in animal models in the setting of active cancer. It hasn't been studied in long-term cancer preventative sense, but there were early studies that were looking at tumorigenesis and tumor regression in response to starvation. And so those early studies, these are very early, these are early 1900s. They did observe regression of cancer with starvation models and with fasting of this nature, but it hasn't been extensively studied to this degree in the modern form of fasting that many people are using now, of overnight intermittent.
Great, thank you.
Very interesting. Thank you. Thank you, Dr. Tenhold.
Of course.
Okay, great. Well, then we will let you go. And just thank you again for your presentation, for bringing us this information.
Of course, and thank you so much for having me.
You're welcome.
Great, thank you. I'll go on to do a few remarks to Madam President. I'd like to just talk a little bit about Veterans Day. On Veterans Day, our nation honors and thanks those who have served our country. At Washington Hospital Healthcare System, we also proudly recognize our healthcare system employees and physicians who have served in the armed forces or are currently serving in the reserves. We celebrate our veterans on a commemorative Veterans Recognition Wall that was installed in 2016, and is updated every November. Located in the Washington West Building, the wall lists the names, military branch, rank, and length of service of our veterans. The individuals listed on this commemorative wall are staff members who work in the hospital, one of our clinics, our outpatient centers, or in our surgery centers. There are also doctors on our medical staff. This year, we added the following 6 people to our Veterans Recognition Wall. First is Manuel Avila. Manuel works in our ICU as a certified nurse assistant. He served in the U.S. Marines for 3 years and achieved E2 rank. Ryan Croft is our respiratory care coordinator. He served in the U.S. Navy for 4 years. He attained E4 rank. Eris Del Rosario is a staff nurse 1 and part of our new grad program. Eris served in the U.S. Navy for 4 years and reached rank of E4. Frank Romano is the Director of Cardiovascular Services and oversees our cath lab. Frank served in the U.S. Air Force for 4 years and attained E4 rank. Pete Vandal. Pete is a respiratory therapist who served in the U.S. Navy for 6 years. He achieved the rank of E4. And Golden Watson. Golden is a senior radiologic technologist at our Institute for Joint Restoration and Research. He served in the U.S. Air Force for 3 years and attained the E4 rank. We should all be proud of the talented veterans who are part of the Washington Hospital Healthcare System family. I'm also proud to say that the healthcare system supports military service, and we have a policy that reflects our support. Our leave policy allows members of the armed forces or National Guard to be granted military leave from work when called to active duty for training, inactive duty training, or active duty. Our military leave program allows servicemen and women who choose to continue their military service to continue serving without fear of their job not being there when they return. And they can do that without facing the financial burdens created when leaving non-military jobs to serve our country. We value and we respect our veterans. Their bravery and selflessness is simply admirable. Regardless of the military branch that they served in, or if they served in peacetime or wartime, we appreciate their service. I invite each of you and anyone in our community to visit the Veterans Recognition Wall next time you find yourself in the Washington West Building. I salute and thank each of the individuals added to our Veterans Recognition Wall in 2022, and the many more who have had their names added in previous years. We appreciate their selfless dedication to our country. Thank you.
Thank you very much. We do appreciate the service of all of our service members and people in our community. We don't understand the full impact of their sacrifice, but we appreciate their service, and especially for those who are working with our patients in our community. Thank you. Well, we will now move on with our reports, medical staff report with Dr. Hyder. We'll start with you. Good evening, Dr. Hyder. Oh, you're on mute. There you go.
Yeah, good evening to all. Let me go through our list of Washington Hospital medical staff. So in anesthesiology, we have 29. In family medicine, it's 43. Out of that, active are 13, ambulatory are 28, and provisional active are 2. In medicine, it's 257 with active 186, allied health 7, ambulatory 29, courtesy 8, provisional active 22, provisional AHP 3, provisional consulting 1, and relinquishment 1. OB-GYN 33 with active 20, allied health 2, ambulatory 2, consulting 2, courtesy 1, leave of absence 2, and provisional active 3, and provisional courtesy 1. Pediatrics, there are 58. Out of that, active are 22, ambulatory is 24, consulting is 6, courtesy is 1, leave of absence is 1, and provisional active is 3, and provisional consulting is 1. And radiology comes to 35, and with active 13, allied health 1, and courtesy 6. So the total active is 339 with administrative 1, allied health 37, ambulatory 98, consulting 8, courtesy 23, leave of absence 5, provisional active 43, provisional AHP is 14, provisional consulting is 2, provisional courtesy is 12, and relinquishment is 1, and the grand total is 583.
Very good.
And the other thing is, we are seeing always our census remain high, but we are pleased to say that COVID-19 hospitalization has been declining, and as a result, the hospital protocol put in place during the pandemic is trying to be easing. While it has been so unprecedented time for everyone, benefits were born from the pandemic, such as convenient telemedicine, which we are used to, and heightened attention on infection prevention. And the entire health system, including administration, physician, and other clinician and ancillary staff, are emerging as an even more unified time, all with primary goal of providing safe and excellent patient care. And we have been building our future with teaching in those who follow us in the profession. In addition to our ongoing UCSF Fellow accredited rotation program, we have added from Toro University 4th-year medical student to our emergency department, and from UCSF graduate level genetic extern working will be in fetal medicine. And the surgical resident from recently from San Joaquin General Hospital will soon accompany our vascular surgeons. So, and the other thing, on behalf of the medical staff, we honored Alameda County Trust in Washington Hospital in awarding Washington Hospital with long-standing opportunity to become a trauma center level 2 in the coming years. And we have to do a lot of preparation, and the credit goes to our board members, administration, especially to Ms. Hartz. Thank you for this.
Thank you, Dr. Hyder.
Thank you.
Service League report, Debbie Fury. Good evening.
Everyone. And greetings from the volunteers. For the month of October, we had 141 Service League volunteers contributed 1,723 hours to the hospital. We also hosted an orientation in October that was attended by 7 adults and 2 high school students. So we got more adults that time, yay.
Yeah.
Next week, the Service League kicks off the holiday season with the annual holiday gift show. It's hosted by the gift shop, and the gift show will take place in the lobby of the Washington Hospital on Monday, the 14th, from 9:30 to 3:30. The Washington Hospital Employees Association is graciously providing cookies for all shoppers and attendees at the sale. So that's at the gift shop. And then I also want to let the community and the district board know that the $5 jewelry sale is returning later this month for 3 days of shopping bliss. The sale is right after Thanksgiving on Monday, the 28th through Wednesday, the 30th in the Anderson Auditorium. And we have 2 huge rooms full of merchandise, perfect for the holiday bliss, for all your shopping needs. In conjunction with the sale, the Service League also will have their the holiday raffle, and it will be at the 1900 building. And there's
1900?
Yeah, I'm sorry, not 1900.
Don't send them someplace else.
Washington West, sorry. Our building, never mind. And finally, as I mentioned last month, our longtime volunteer, Charlie Razier, passed away early in October, and he staffed the lobby at the hospital for 20 years. And the Service League received a significant number of memorial donations for Charlie. So we're offering a scholarship in his name for 2023.
That's nice.
So, and that's the report for the month. If you have any questions.
Thank you, Debbie.
Sure.
Nice way to honor Charlie's legacy
Yeah,
with a scholarship. That's wonderful. Thank you.
sure.
All right, next up, we have Mary Boron with our quality report. Good evening, Mary.
Good evening. Thanks for having me here. I'm going to be covering the quarter ending September of 2022 quality data. And so again, that includes data from July, August, and through September of this year. I'm going to start off with the infection control indicators. Our first one was looking at hospital-acquired MRSA, which again is a very difficult infection to treat. If it's identified in a patient's blood within 72 hours after admission, it's considered hospital-associated. We did not have any this quarter. That puts us 2 quarters in a row without MRSA, which is less than expected. So we achieved that goal. Moving into our catheter-associated urinary tract infections, otherwise known as CAUTI. We did have 1 CAUTI infection this quarter. The CDC predicted that we would have 1 and potentially be at risk for having higher than 1. So we're at a little less than predicted. 1 is still too many for us. We do a root cause analysis on each one of these. They're looked at by the infectious disease consultant. We work with nursing closely on these and our infection control staff. Again, overall, this is good though, because it's less than the expected, which is really a reflection of getting catheters out of patients when they're not needed and making sure that we're taking care of a patient while they have a catheter in place, because it can be a high risk for developing CAUTI. For our next one is central line associated bloodstream infections, otherwise known as CLABSI. So for this quarter, we did not have any CLABSI, so that's great. It's actually a reflection of less than expected by the CDC that predicted we'd have closer to 1.7. And this is good also because, as you can see, it's sort of been trending down. Again, even 1 would be something that we would do root cause analysis on, like we did the prior 2 quarters. We're happy to report 0 this quarter. Our surgical site infections are something that we monitor really closely at the hospital. We look at about 35 different procedures every month and a survey to make sure that the patients didn't get any infections after having a surgery here. And we overall have a very low surgical site infection. We do go over 2 high-risk groups, and one of which is colon surgery. Because of the nature of the organ that you're doing surgery on, it's higher risk for getting infected. And we're really happy to see that we've continued to have a steady stream of having 0 infections, and that always been less than predicted by the CDC for now the 5th quarter in a row. So this is a great reflection of how our practices are, from our surgeons to the people who maintain the OR rooms, EVS, nursing, everybody who's involved in the OR process. This is one of the outcome measures that shows that that's working well.
Good.
And then moving into our next one, which is our hysterectomy, is another high risk surgery. So this is one that we tend to focus on clearly. Also, again, we're seeing a 6th quarter in a row here with 0 infections. It's also reflective of great care from as I mentioned before, at the other surgeries, everything from right from the surgery starts to all the way afterwards and post recovery. C. diff is a spore that is also very difficult to treat with antibiotics, and we have really had a lot of success this year with controlling our C. diff, and this last quarter really shows that again. For this quarter, we had 0 C. diff infections, and you can see that it's something that across the nation hospitals struggle with. Even for our size of our hospital, size of our type, the CDC predicts closer to 10 infections, and we are at 0. What this is really a reflection of is a whole team working together, the multidisciplinary team, really right from the beginning of the doctor knowing when to test and order a test for C. diff, Nursing works closely with the medical staff on looking at appropriate testing. This also tells us that we do not have a transmission-based problem because patients didn't acquire it while they were here. So it's a reflection of good practices around hand hygiene, isolation, etc. So happy again to report 0 infections. Again, a sustained great result. Hand hygiene is something that, as you know, we continue to work on, and it will always be something that we have to work on all the time in the hospital, on getting healthcare workers to wash their hands when indicated. This quarter, we were at 80%, which is unfortunately a decline from where we had been really getting close to goal the last 2 quarters. So we look at the data on the healthcare workers that are observed not washing their hands, and we are actually able to have discussions with them and kind of hear a little bit more about things that we can do to make hand hygiene products more accessible, or education on when to wash your hands. And again, like I said, this is an ongoing hospital priority. It always will be. It's one of our focuses that we'll continue to work on with patient safety moving into the calendar year. And a lot of it has to do with, like I said, educating, consistently having observers out there watching people and how they interact. And it's not meant to be punitive. It's meant that an infection preventionist who's out there watching to make sure people are washing their hands, it's good for them to have conversations with the healthcare workers. And it's a reminder of how important hand hygiene is, since it's the single most effective way that we can stop the spread of infection in the hospital. So we're hoping to see that come up closer, and if not exceed goal, moving into the next year. Our nurse sensitive indicators, again, are an area of data that we look at that really are supposed to give us a insight to how practices in nursing are being reflected in outcome data, such as if a patient falls. And in this case, we had far less expected falls than the national benchmark of NDNQI, which is a database that gives us benchmarks for magnet hospitals. And so even against a magnet benchmark, we are lower, which is great, had less than expected. This is a reflection of 4 minor falls with no serious injury. There were some abrasions for these patients. And again, we look at that really closely to see what we can do to prevent the falls. But again, the overall outcome of this is that we are doing a great job with placing our patients in an area where they can have great visibility to the nursing station, patients that are high risk for falls, rounding on patients frequently to make sure they have assistance going to the bathroom, and making sure that they have their call lights near them, et cetera, all that. So I'm really happy to see this again for multiple quarters in a row, that our patients are being carefully watched who are at high risk for falls. Our hospital-acquired pressure ulcers, otherwise known as bed sores, are something where we have also seen really sustained low incidence. In this quarter, we had 0 hospital-associated pressure ulcers. Again, this is a great reflection of a nursing sensitive indicator. It can kind of give you some insight to these patients are having great skin assessments while they're here, and we're rotating the patients frequently. We have them on the beds that they need to be on that will decrease their risk of developing pressure ulcers. There's also a whole nutrition factor. So I think there's a lot of things that go into this, even like I said, beyond nursing with regards to FNS's input, things like that. But overall, continue to see a great outcome here for the 5th quarter in a row. Readmission rates are something that we continue to see challenges with. In fact, as you can see, we have had a great deal of success in the metrics that we've just reviewed, and overall it's been a good quarter. The part of the data that needs to be focused on, though, is reducing readmissions. And starting off with our AMIs, otherwise known as heart attacks, this is actually lower than what was expected from CMS. We did have 2 patients readmitted within 30 days after being in the hospital, putting us at a rate of 11%, and the national benchmark would be around 15%. So AMI patients were not an issue for readmissions this quarter. Pneumonia had been a real challenge for us. As you can see, back in late 2021 and even earlier this year. This has been a group of patients that we've really watched closely, done some real analysis on all patients coming back, and it is on a downward trajectory. This is a great outcome that we've been working towards, having only 3 patients readmitted, putting us at a less than expected readmission rate compared to what CMS has. So we were at 12%. CMS national benchmark is closer to 15%. So while we don't want any readmissions for patients to have to come back to the hospital unnecessarily, or we work to help prevent their readmissions, again, this is going well. Some of the efforts we've been putting into pneumonia, I think, are actually at a trend point now, where we can say that those efforts of making sure that patients have a follow-up appointment with their doctors, have transportation set up, have the right medications, get a follow-up phone call from a pharmacist. These are all the things that we do for this high-risk population, and we are starting to see some of the benefit from that. However, moving into heart failure, again, this is where I said we're going to be focusing closer on these high-risk groups with heart failure. While this has declined over the last 3 quarters, we did still have 15 patients readmitted. That puts us at a readmission rate of 22.4%, which is higher than the CMS national benchmark of 21.3%. These patients are very similar to pneumonia patients, but even this group was even more high risk in this last quarter. One of the things that we do is we look at the data of the patients who came back, because you can get a lot of insight from looking at them, like what made them come back, what were the issues, and learn from that so that we can help prevent other patients from having to be readmitted. This particular group did stay for the full expected length of stay, and some of them were even in the hospital longer than expected. So in this analysis, it is not about prematurely discharging patients, as I said, because most of them even stayed longer than expected. They were very sick patients. The average age is 80. And they had, of course, chronic comorbidities around heart failure, diabetes. The majority of these patients also did leave with other services, meaning that we didn't just send them home. They went home with home health, or they went to a skilled nursing facility. They had some extra support, and in spite of that came back. And the majority of that group was in patients that went home with home health. So we're working really closely with those home health agencies. Our transitional care nurses will be talking to the home health agencies daily about these high-risk patients, see if we can catch things earlier going on with their chronic illness of heart failure, and do interventions earlier so that the patient can remain at home and only be admitted if absolutely necessary. In these cases, these patients did need to be admitted, which we're very clear and very supportive of the medical staff here. If a patient comes in, needs to be readmitted, of course, we're readmitting them to get them the care they need. But 15 is higher than expected, definitely. We want to work on that. COPD, unfortunately, saw an increase for the 2nd quarter in a row, with 4 patients coming back. A lot of the similar trends that I mentioned in the heart failure population does exist with this population also, although the 4 people who came back were younger than the heart failure population. This group was closer to average age of 75. They did go home with home health agencies. And again, we're taking the same approach that we're using on heart failure with our COPD patients, which is another chronic illness, difficult to manage, and often leads to being readmitted to the hospital. So watching them closely with our home health support. Coronary artery bypass graft, otherwise known as a CABG, procedure that patients have after having an AMI or other cardiac conditions. It looks on this chart, looks fairly daunting at 50%. I just want to point out really clearly that we are only looking at 2 patients. These are patients that we obviously do more CABG procedures in a quarter than 2, but the way that this metric is set up is it's specific to Medicare patients. So one of the patients who had surgery did return. This patient came back actually 15 days after discharge for issues related to low blood pressure and pain and some electrolytes. So the patient absolutely needed to be admitted and recovered very fast and was discharged home, luckily within 2 days. But it still is obviously counts as a readmission and is higher than expected. Our last one is our patients that have their knees and hips replaced. The metrics and the nation and CMS are very low tolerance for what is too many readmissions in this patient population, because they are a patient population that have an elective surgery procedure and are not likely to have to come back to the hospital. So CMS as national benchmark is about 4.1%. We only had one patient come back out of 12, but because the denominator is so low, it still put us at 8.3. This one patient did get readmitted. They were readmitted on the 19th day after being discharged in something that is completely unrelated to their surgical procedure and was cardiovascular related. And they were admitted and that was addressed and they were able to be discharged. But as I said, again, not related to the surgery, but because their primary reason they were here 30 days ago was a procedure with having, in this case, a hip replaced, they do fall into this metric. And thank you. I'm happy to answer any questions.
Thank you, Mary. Any questions for her? Good. Keep up the good work. Thank you for your team. Great. Thank you. All right, we'll move on ahead with our finance report from Chris Henry. You're on mute.
Okay, let me try that again. Tonight we'll be looking at the operating and financial results for Washington Hospital for the month of September. And as always, we'll start with our acute inpatient statistics. Our inpatient average daily census for September was 4.1% higher than we expected in the month at 159.1. Our combined average daily census, which includes our outpatient observation days, came in at 167.2, about 2.4 below the budget of 164.8. Admissions for the month came in at 850. That's about 4.2% higher than the budget. Patient days for the month came in at 4.1% higher than the budget at 4,774. Our outpatient observation equivalent days for September came in 115 lower than budget at 242. And our average length of stay was 0.17 lower than budget at 5.45 days. Looking at utilization. Case mix index for the month came in pretty close to budget at 1.594, about 0.014 lower than budget, so very close to budget. Deliveries for the month were 16 lower than budget at 114. Our surgical cases for the month came in 9 higher than budget at 307. Cath lab cases came in pretty low for the month at 144. We'd expected 227. And as you're aware, we've had some turnover with physicians in that area, so that's affecting our volumes. Outpatient visits for the month came in 320, lower than budget at 8,709. And our emergency room just continues to be busy. They saw 4,737 visits against the budget of 4,662. Looking at the detail of our surgical cases and cath lab cases in the OR, our joints and neurosurgical cases came in higher than budget, as did our other surgical cases category. Cardiac surgical cases for the month came in 3 lower than budget at 10. In the cath lab, really lower across all categories. Cardiac, as you can see, lower than budget at 31, peripheral vascular lower by 26, Non-vascular interventional radiology also lower by 26. Neurointerventional radiology cases, however, came in on budget at 7. Moving into our productivity indicators, productive FTEs for the month were 16.4 lower than budget at 1,390.3. Non-productive FTEs were 22.5 higher than budget at 219.1. That includes 10 FTEs related to the supplemental COVID sick pay program that's going on in the state. That'll keep going on until the end of December and end if they don't extend it again. Total FTEs for the month came in 6.1 or 0.4% higher than budget at 1,609.4. And our FTEs per AOB, or FTEs per adjusted occupied bed, which is our productivity indicator, came in at 6.04, which was below the budget of 6.19. Moving into the financials, as always, we'll look at our Governmental Accounting Standards Board format first. This is the format we use for our audited financial statements. Total patient revenue for the month came in $5.57 million lower than budget at $189,049,000. The vast majority of that was the result of the lower volume in the cath lab. Contractuals for the month came in higher than budget at 77.68%. We'll move into there. Our contractual allowances, which are related to our insured patients, came in a little bit lower than budget, about $2 million lower in budget at $143,928,000, or 76.13% versus 75.03. We did have in that bucket a high number of workers' comp and TRICARE cases that affected that. Those cases were overweighted compared to budget, and they're not good payers, so they really did drive that contractual up. Our provision for bad debt and charity for the month came in $783,000 lower than budget at $2.9 million, and giving us total deductions that were almost $2.9 million lower than budget at $146,850,000. So we ended the month with net operating revenue about 6% lower than budget at $42,657,000. Operating expenses for the month came in $263,000 lower than budget at $42,620,000. Salaries and wages were lower by about $100,000. Even though our FTEs were slightly higher, the mix in the FTEs resulted in lower wages for the month. Benefits came in $372,000 higher in budget. We did see higher number of health and welfare claims processed during the month, driving that number up. Supplies came in below budget, about $314,000. About $182,000 of that came from drug costs. Our stents were lower than budget by about $88,000, and our cardiac and neuro supplies came in lower than budget also. Rounding it out, our insurance, utilities, another category came in below budget, just under $200,000. So we end up the month of September with an operating bottom line just above break even at $37,000 against a budget of just under $2.5 million. And again, that lower volume in the cath lab really impacting our financial results in the month. Non-operating income for the month came in with a loss of just under $2.5 million. We did have an unrealized loss on our investments. It's a tough financial market out there right now. Our unrealized loss on investments was $2,572,000. So we ended the month with a total net loss of $2,437,000. We actually expected to make about $2.4 million in the month. Moving into our Financial Accounting Standards Board presentation. What we do here is we adjust those GASB financials in a way that the financial markets might do when they take a look at our financial results. First thing we do is we reclassify about $560,000 of interest expense related to our revenue bonds out of the non-operating category and up into operating expenses to end up with an operating loss from a FASB point of view of about $523,000. We then eliminate our general obligation bond interest expense, our general obligation bond tax revenue that supports the debt service on those bonds. And that unrealized loss of about $2.6 million, FASB does not recognize those items. So we actually end up with non-operating income from a FASB perspective of $302,000 against a budget of $201,000, and net loss from a FASB perspective of $221,000. Moving into our earnings before interest, taxes, depreciation, and amortization. This is the way we look at what our operations are generating in cash. First thing we do is we look at we pull depreciation expense out of our operating expenses. But to come up with operating expenses of $39,000, basically $39 million, sorry, not 39,000. And we end up with earnings before interest, taxes, depreciation, and amortization from operations of $3.652 million. We then go down to our non-operating category and we factor out our interest expense. So between and ended up with a non-operating loss of about $747,000. So in total, Washington Hospital's operating and non-operating activities provided about $2.9 million in September for debt service, capital expenditures, and future program development. So are there any questions on September? Okay.
No. All right. All right, Kimberly, you're up.
All right, thank you. I'd like to present the October 2022 numbers, starting with the gross revenue. Gross revenue of 191.7 million for October was below budget by 1.4 million or 0.7%, and was above October of 2021 by 3.4 million. Inpatient gross revenue of 116.2 million was above budget by 2 million or 1.8% and 6.8 million above October of 2021. Room and board, surgical services, and inpatient ancillary services were all above budget, but our inpatient cath lab was once again below budget. In terms of outpatient gross revenue of 75.5 million was below budget by 3.4 million or 4.4%, and 3.4 million below October of 2021. Our outpatient surgery or cath lab and outpatient observation revenues were below budget. In October, there were 35 adult COVID-19 discharges, representing about 4% of total discharges. This was a decrease of 6 cases from the prior month and was 17 more than October of 2021 at 18 discharges. Moving on to our key census statistics, the average length of stay of 5.2 was below the budget of 5.59 by 0.39 or 7%. This was also lower than the October of 2021 average length of stay of 5.24. There were 8 discharges with lengths of stay greater than 30 days, ranging from 33 to 112. Excluding these outliers, the average length of stay was 4.76. Still in-house at the end of the month, we had 4 patients with lengths of stay over 30 days, and they ranged from 33, they were 33, 36, 50, and 89. So again, I think our multidisciplinary approach to ensuring that patients are in the right level of care has been beneficial in terms of looking at these long lengths of stay. Our outpatient observation days at 260 were below the budget of 346 by 86 days or 24.9%. and 69 days below October of 2021. The new portal of entry program is resulting in decisions regarding patient placement being made more quickly. So patients are spending less time in observation and really in the appropriate level of care. Our inpatient average daily census of 150.1 was above the budget of 145.6 by 4.5 or 3.1% and above the budget and above October of 2021 average daily census of 142. The combined average daily census of 158.5 was above the budget of 156.8 by 1.7 or 1.1% and 5.8 above the October 2021 average daily census. The combined average daily census includes observation equivalent days. Moving on to our admissions trend, admissions of 912 were above the budget of 807 by 105 or 13%. October 2022 admissions were 130 above October 2021. In October of 2022, 84% of the admits were medical and 16% were surgical. In October of 2021, 83% of admits were medical and 17% were surgical. So similar in terms of the percentages. Looking at our patient days of 4,654 were above budget by 140 or 3.1%. And were 251 days above October of 2021. Our adult med surg days were higher than budget by 214 days or 6.8%. There were 1,214 days were surgical and 3,440 were medical days. Our OB, PEDS, and NICU days were higher than budget by 41 days, but our ICU and IMC days were lower than budget by 116 days. Looking at our surgical trend, our total surgeries in October of 371 were above the budget by 9 or 2.5%, and surgeries were 9 above October of 2021. Our inpatient surgeries at 148 were 16 or 12.1% above budget and 21 above October of 2021. Our outpatient surgeries at 223 were 7 or 3% below budget and 12 below October of 2021. Looking more specifically at our surgical activity, our joint replacement surgical cases were below budget by 5 or 3.2%, but were 21 below October of 2021. Our joint replacement cases are expected to decrease from prior year as the Peninsula Surgery Center ramps up our operations. And as you know, Peninsula Surgery Center started billing Medicare on Monday, October 3rd, and we're still working on contracts with certain contractors. We do have contracts with Aetna and United Health that went into effect in October. So in October, Peninsula Surgery Center performed 27 surgeries, but were budgeted for 30. So just a few below what they were budgeted. Our neurosurgical cases were below budget by 10 or 33.3% and were 2 below October of 2021. We had all 3 of our neurosurgeons, some were out and they did perform fewer than they had in terms of last month. I think one of them was out on ETO too. Our cardiac surgical cases were on budget, but were 1 or 12.5% below October of 2021. All other surgical cases combined were above budget by 24, 14.9%, and 32 above October of 2021. Moving on to our cath lab. Our cath lab cases for October we continue to see some challenges. They were at 177. That were 43 or 19.5% below the budget of 220 and 42 below October of 2021. Our cath lab inpatient cases at 102 were 19 or 15.7% below budget of 121 and 17 below October of 2021. Our outpatient cases at 75 were 24 or 24.2% below budget of 99 and 25 below October of 2021. Looking at the breakdown of the cath lab activity, cardiac cases were below budget by 16 or 17.4%, and 7 below October of 2021. Our non-vascular interventional radiology cases were below budget by 14 or 20.6, and 25 below October 2021. And peripheral vascular cases were below budget by 11 or 20.8%, and 8 below October 2021. Lastly, our neurointerventional radiology cases were below budget by 2 or 28.6%, and 2 below October of 2021. We are in discussions with a number of our cardiologists and our IR physicians in terms of talking about ways that we can look at what they're seeing in their office and how it's translating into the cath lab activity. Looking at our deliveries, they were for October of 122, were below budget by 3 or 2.4%, and 13 below October of 2021. Our non-ER outpatient trend, our non-emergency outpatient visits of 9,140 were above budget by 145 or 1.6%, and above October of 2021 by 1,126. This increase was primarily driven by our cardiac rehab visits, which were 54 higher than budget or 8.1%, and our x-ray visits were 71 higher than budget at 4.1%. Our emergency room continues to be busy. We saw visits of 4,970, which were above the budget by 305 or 6.5%, and 761 above the prior year. In this month, the emergency room saw an increase in visits due to respiratory viruses, including RSV. Moving on to our gross revenue recap. While surgical cases were above budget by 9 cases overall, or 2.5%, our revenue was slightly below budget by 67,000 or 0.2%. This is mainly driven by the service mix of surgeries we had 16 or 8% fewer than high revenue cases. Our room and board revenue was below budget by 633,000 or 1.7%. There were higher patient days in October than budgeted, but revenue was below budget due to lower utilization of ICU and IMC beds. Observation days were also lower. Our deliveries were below budget by 3 or 2.4%, driving revenue below budget by 141,000 or 4%. Our emergency visits were above budget by 305 or 6.5%, and our emergency room revenue was above budget by 457,000 or 3.7%. Our cath lab cases were below budget by 43, and revenue was 2.9 million or 20.8% lower than budget. And then lastly, our ancillary services revenue was above the budget by 1.9 million or 2.1%, due to higher activity in inpatient and outpatient services. Moving on to our preliminary payer mix, government-sponsored patient revenue made 71.7% of total gross revenue. This was slightly higher than the budget of 71.4% and higher than the prior year's percentage of 70.4%. HMO was 1.8% of gross revenue, below the budget of 2.6% and lower than the prior year's percentage of 2.8% of gross revenue. PPO was 25.1% of gross revenue, which was above the budget of 24.4%, but slightly lower than the prior year's percentage of 25.4%. Then lastly, private pay was 1.4% of gross revenue, below the budget of 1.6% and consistent with the prior year percentage of 1.4% of gross revenue. Looking at our productivity indicators, our productive FTEs were above budget by 65.1 or 4.8% at 1,434.7. Our non-productive FTEs were below budget by 12.7 or 7.7% at 151.6 FTEs. The number of FTEs that were out on the COVID-19 supplemental sick leave were 5.9. This was lower than September of which was 9.96 FTEs, and August was 20.6 FTEs. And as Chris mentioned, this does continue to be in effect till the end of December. Looking at our total FTEs of 1,586.3, that was above budget by 52.4 or 3.4%. Of the total variance, 10.6 FTEs were due to higher volumes in the month. And the remaining variance really was primarily due to the timing of our annual nursing skills training and the start of the new grad program and many training programs and or training positions that we've opened up. And this is really for us in terms of looking at ways to retain our employees and provide them with opportunities to learn skills in different areas. Moving on to our productive FTEs per adjusted occupied bed, came in at 5.79, which was higher than the budget of 5.56 by 4.1% or 0.23, and higher than the prior year of 5.45 by 6.2% or 0.34. So overall, our total FTEs per adjusted occupied bed of 6.4 were higher than the budget of 6.23 by 2.7% or 0.17, and higher than the prior year of 6.09 by 5.1% or 0.31. And again, I know we are came in over budget as mentioned, but really a lot of this was due to the timing of training and skills training. All right, moving on to our preliminary outpatient statistics. The Whitman clinic visits were below budget in October by 1,407 or 7.9% at 16,323, and 1,377 visits below October of 2021. Our cardiology was below budget by 239 visits due to some equipment issues that we had that is now fixed. We also have some open positions in a few of our clinics, including ENT, urology, and vascular. And we also had a few of our providers that did take time off. Those were the main reasons. Then moving on to our DevCo outpatient visits, came in at 2,427, which was above the budget by 134 or 5.8% for October, and 223 above October of 2021. Our Washington outpatient rehab center volume was consistent with budget. It's right on budget at 1,389 visits. Good budgeting. Radiation oncology center treatments have continued to be above budget, and they came in above budget by 95 or 27.8%. Our Washington outpatient surgery center visits were above budget by 6, so 1.2%. Our Peninsula Surgery Center visits, as I mentioned, were below budget by 3. They came in at 27. And our Ohlone College Student Health Center visits were above budget by 36. Looking at our key financial statistics, our days cash on hand for October ended at 155 days, an increase of 1 day from the last month. Our days in accounts receivable in October were 61.5. This is down 0.9 days from September due to strong collections, and 5.5 days below October of 2021. And there were 457,000 in charity care adjustments in October of 2022. So our days in AR have been making good progress. And now on to the homeless patients activity summary for the quarter. We had 305 patients, resulted in 462 patient encounters with Washington Hospital during July through September of 2022. 80 patients had multiple encounters with the hospital. The estimated unreimbursed cost of homeless care decreased compared to the prior year by about 17%, but remains relatively constant on a per encounter basis. The cost of homeless care includes food, clothing, pharmaceuticals, transportation, and housing, in addition of hospital staff labor and avoidable inpatient days. Right, those were the preliminary statistics for October. Any questions?
Thank you, Kimberly. You can go on with announcements if you'd like.
All right, thank you. I'm going to start with the November employee of the month. Vincent De La Cruz, he is our desktop support engineer. When a computer freezes or a document is lost, most people quickly start to panic. Employees of Washington Hospital, however, can pick up the phone and call our service desk. And if the service desk cannot solve the problem, there is still no reason for alarm because soon to the rescue will be Vincent De La Cruz, a desktop support engineer. Vincent is a born problem solver. He enjoys puzzles, analyzing the problem, and figuring out a solution. When he joined the information services team at Washington Hospital in 2013, he was a contractor working on the Epic Go Live. Vincent was one of the team members who made certain the hospital computers were ready for this critical upgrade. His strong work ethic and technology expertise resulted in a full-time position. Vincent is asked often to assist with computers throughout our hospital campus. He enjoys seeing how the work of each department is like a cog in a machine that results in excellent patient care. Vincent knows that if a system is down, and it impacts the work of our healthcare providers. In this way, all of the IST contributes greatly to the patient first ethic. His manager, John Bell, praises Vincent's attention to detail when documenting policies and procedures and his willingness to learn from multiple projects. Vincent was key in the business continuity access project, which is vital if an unexpected event forces computer downtime. Vincent enjoys his role at Washington Hospital so much that he commutes from Hollister to work. When not at work, he enjoys an active outdoor life with his wife and 13-year-old son. Bass Lake is a favorite spot for camping and hiking, and recently they enjoyed camping at Shaver Lake. So congratulations, Vincent De La Cruz, on being our employee of the month for November. All right, I'm going to move on to a few more announcements and talk about it. I've put together a couple of slides so that it's easier to follow, especially for the community in terms of talking about our educational events. So beginning with those that have happened, I just want to mention on October 13th, we had our 14th annual Think Pink Breast Health Awareness event, and we had over 250 attendees. On October 15th, we had the Wave of Life Memorial, and this is really in recognition and loving memory of pregnancy loss and infant loss. And what this is when each person lights a candle at 7 p.m. their time, and they keep it lit for 1 hour, and it's literally a wave of light that passes from one time zone to another. We also hosted on October 16th the Blue Dot Walk, which is the maternal mental health awareness event. We had 71 participants. On October 18th, Christy Caracappa presented Medicare, What You Need to Know, and we had 98 live views and 553 accessed it later. On October 23rd, we had Tammy Tyson, our Director of Oncology, and Christine Mickelson, Women's Center Coordinator. They spoke, did a staff presentation to the San Francisco Louis Vuitton store, and they talked about breast cancer prevention, early detection, and treatment. On October 25th, Dr. Nord and Dr. Michael Golden did sports physicals for 5 schools in the Fremont and Newark districts. You can see 51 physicals were provided. On October 27th, Dr. Jet Liu, our orthopedic surgeon, spoke on common foot and ankle problems at Fremont Hills Retirement Community, and 12 residents attended. Then on November 2nd, Dr. Jack Rose talked about stroke awareness, the risk factors and prevention, and we had 156 live views and 348 accessed it later. Excuse me. November 3rd, our Washington Sports Medicine program supported the Special Olympics elementary soccer tournament, where they did the first aid station and medical coverage. You can see that there were about 255 athletes. Looking at our vaccination clinic, to date, as of November 3rd, we have given 95,589 doses. And for the 6-month to 4-year-olds, 574, and 5 to 11-year-olds, 3,839. So If there are individuals who are interested in getting their vaccination, they just can call to schedule. Moving on to upcoming health promotion and community outreach events. On November 9th, Ryan Croft in respiratory therapy was going to speak on breathing easy, managing asthma. On November 15th, Elisa Curry is going to speak on fall prevention and recovery at the Fremont Hills Retirement Community. November 18th, Wahia Khan is a licensed marriage and family therapist. She is going to speak on Facebook Live and YouTube on self-care and self-compassion, keys to well-being. On November 18th, again, our sports medicine program will be supporting Special Olympics, junior high and high school soccer with first aid and medical coverage at American High School. November 21st, again, our Director of Oncology, Tammy Tyson, along with our Women's Center Coordinator, Christine Mickelson, is going to be speaking on breast cancer prevention, early detection and treatment at the Masonic Homes Retirement Community. November 22nd, Dr. Norwa Mustafa, a cardiologist, will talk about heart attack prevention at Acacia Creek Retirement Community. And then on December 1st, he is going to be talking about treatment options for aortic stenosis on Facebook Live and YouTube. Followed on December 8th by Dr. Prasad Kata, our endocrinologist, who's going to be talking about understanding and controlling complications of diabetes. This will also be on Facebook Live and YouTube. Lastly, just a report on the Washington Hospital Healthcare Foundation. The foundation hosted the 36th annual Top Hat Gala on Saturday, October 8th. After expenses, the dinner dance raised $253,000 for Washington Hospital's Trauma Center. We're also are happy to announce we'll be hosting a community tree lighting event on Wednesday, December 7th at around 5:30 p.m. And this will be an event featuring entertainment, special with special, what do I want to say, person coming, Santa Claus, and other refreshments, and all will be welcome. We'll be having some other information on this in the upcoming next meeting in terms of it. So I think that is it.
Great, thank you. I appreciated being able to read along while you're speaking.
Yes, I was trying to see if that would be easier to follow.
Yeah. Thank you. Great. Any other questions for Kimberly?
Nope, that's it.
Okay, very good. Well, there being no need for a closed session tonight, we will go ahead and adjourn this meeting, and thank you all for your attendance. Have a good evening. Thank you. Good night.
Good night.
Good night, everybody. Good night.
Good night.